All right.
We can leave it at that.
Okay. Hello, everyone. My name is Ruth Jo Priest, and I am the Health Information Technology Manager for the Wyoming Department of Health. And I am thrilled at the participation. How many do we have online?
We currently have 14 participants.
14 participants online. So this is the official kickoff for the Wyoming Frontier Information Steering Committee meeting. And our logo, as you can see, is a lovely green and brown buffalo designed by Tim Caswell. And the name of our project is Wi-Fi. Some of the things that we want to talk about today is we want to discuss some of the background, have some introduction, and gather information and hopefully participants for all of our subcommittees. So as I said, I'm Ruth Jo Priest. We have a number of our state internal people working on this project, and I'd like you to introduce yourself. I've got Tim Caswell.
I'm Tim Caswell. I'm the EHR program specialist. Really, mainly what I do is work with a lot of data in the Medicaid program. And we have Andrea Bailey.
Andrea Bailey, I'm the HIE Outreach Coordinator. I help providers meet their meaningful use initiatives.
Okay, we have Dr. James Bush in the corner.
Hi, Dr. Bush. I am Wyoming's Medicaid Medical Director and Chairman of the Wyoming Telehealth Consortium.
We have Jesse Springer. Say a few words, Jesse.
Jesse Springer. I run a technology unit here in Medicaid.
We have Jerry Laska.
I'm a legal analyst with Medicaid.
Angie Van Houten.
I'm Angie Van Houten, the Community Health Section Chief and part of the Public Health Division.
And Dallas Lane.
I'm Dallas Lane. I'm the Privacy Officer and Security Officer for the Department of Health.
And we have an ETS representative.
I'm Rick Joplin. I work with the Systems Group over in ETS.
We have our consulting group, public consulting group, which is PCG, and they have been instrumental in the background and the planning for this project, and I'll let you introduce yourself.
Hi, everyone. I'm Natalie Blahanka. I'm a business analyst with Health PCG, and I am here to support the project. I'll be banging away notes over here, so don't mind me sitting in the corner. We have two teammates and colleagues who were not able to make it today. Jan Patterson is our project manager, and you might see these faces in the future. She has been very actively involved in the high-tech legislation since its inception in 2009, and will be working closely with Ruth Jo and the rest of the WDH and PCG team. And then we also have Kim Quinn, who is a consultant with PCG Health, and she will be helping with a lot of the steering committee materials and relations, so you'll become familiar with Kim as well.
My name's Chris Smith. I'm the technical architect. I specialize in clinical data exchange and interoperability between disparate systems, especially clinical systems, EHR, lab systems, things like that. Very excited to be here and working on the project.
I'm Linda Kramer. I am a consultant with PCG. I'm the HIE kind of subject matter assistant for them. I was in Ruth Jo's seat before I came over on the other side.
George Raposo, consultant with Public Consulting Group. I handle the project management activities for the HIE project.
Okay, and could we have everyone else in the room introduce themselves, starting with Deb Anderson.
Hi, I'm Deb Anderson with Mountain Pacific Quality Health, which is a CMS Quinn QIO organization, and I also work for Health Technology Services, which was the regional extension center for Wyoming and Montana. We are the group that received the high-tech funding to help the providers and the hospitals select and implement their EHRs and meet meaningful use.
My name is Kevin Carey. I'm Enterprise VP with VolScripts. promoting all things, all scripts across a 5-state Rocky Mountain region plus Indian country. We recently acquired, about 3 or 4 years ago, a company out of Israel called DB Motion, and we actually support a number of interoperable platforms around the country, deliver those into markets like Central Texas, province of Manitoba, country of Israel. So we have a vested interest here in making sure that we get the information across about who we are and what we can do to help support your endeavor here in Wyoming.
I'm Mike Henningsen. I'm with Allscripts also. I work with Kevin. I focus on the DB Motion interoperability platform, and I'm out of Denver.
Morgan Honey, I'm the CEO of COREO, the Colorado Regional Health Information Organization. We were one of the HIEs in Colorado and also the Regional Extension Center for the state. So I'm very happy to be here. Thanks for having me.
I'm Terry Johnson, and I'm the practice manager with Babson.
I'm Linda Van Dorn, and I'm the practice manager at Roach.
I'm Debbie Hendershot. I'm the project manager for Dr. Carol Fisher's practice.
I'm Sheila Bush, the executive director for the Wyoming Medical Society. And then we're going to have phone introductions.
So those on the phone, if you could introduce yourself one at a time. Tim's going to read off the list of participants, and if you could just say your name and a little bit about yourself, that would be greatly appreciated.
We can first start with Kim, if she can hear us. Kim, are you there? Maybe not. Let's switch over to Dr. Gee, if possible. There we go.
Hi, can you hear me okay?
If you could speak a little louder, please.
All right, Dr. Alan Gee from Cody, Wyoming. I'm a neurologist and had a longstanding interest in health information technology and health information exchange. Impressed by the number of people that are interested in on this call.
Thank you. And then over to Eric. Muted right now.
IT director at Cody West Park Hospital. I've been here about a year and a half and look forward to working with you. This is exciting.
Thank you. Dr. Barnes?
Patient-centered medical home, EMR since 2010.
And Dan Golder?
Hi, I'm Dan Golder. I am a principal with Impact Advisors specializing in healthcare strategy, particularly around electronic medical records. Before joining Impact, I actually was the project director for the Epic install at Cheyenne Regional. So now living in Cody and very interested in how we can leverage technologies to help the citizens of Wyoming.
Mark Domsky? Sorry if I said that wrong.
Yes, my name is Dr. Mark Domsky. I'm an anesthesiologist in Jackson, Wyoming. I have a special interest in HIEs and chief of staff at the hospital. I think it's critical that we approach this and can really make our state a platform for other states to follow through. Since we do have such a small population, I think we have the opportunity to really integrate communication between healthcare entities in the state.
Brenda doesn't Mike. So Pimon Ha1. Oh, Pat Monahan. If you have the mic. Oops, maybe not. Ryan Hedges. Okay, guess not. Oh, there he is. Ryan?
Oh, hello. This is Jessica first, and Ryan has just stepped out, but he'll be right back. And we're both here with, I don't know, excited to be here in Lander, Wyoming.
And T. Reber. Hello? Yeah. And then Kyle, if you could unmute the telephones just as they show up, and we'll have them introduce themselves. So whoever's number is 632-2434, if you could introduce yourself.
Sure, this is Pat Monahan. I'm the clinic director for the family practice residency here in Cheyenne.
And then phone number 332-7300.
Yeah, hi, this is Garth Reber. I'm the family doc and the chief medical officer at Fort Wasky Indian Health Service, and I'm excited to hear what we have to say.
And then the last number is, might be Jan, 888-752-8250. You guys left? Yeah.
Okay. So one of the first things we're going to do is a bit of housekeeping. So I do want you to know that there are beverages and snacks at the table on the west side of the room. So help yourselves, please. One of the primary things that we need to do is we do have a non-disclosure or a disclosure of information statement for conflict of interest. And that is going to be one of the criteria for being a member of the subcommittee or one of the steering committee or any one of the subcommittees. Because a lot of this background will be going into the creation of an RFP, it's critical that we not have any type of bias toward any type of technology or vendor. So where we want your participation, we do need full disclosure of, any proprietary software that you may represent or any vendor that you may represent. That will not exclude you from participating. However, any details of the RFP or any of the technical details at a particular level will not be privy to. But we do want your participation and engagement at all steps of the process. But we will require that this disclosure be allowed to join one of the committees. So I just want to, and that will also apply to the people on the phone. We do want your participation, and that will be sent out with your final task. So are there any questions about that? We do have multiple legal counsel here. So just so that's perfectly clear, and then we'll just move on. Technical problems, what can I tell you? So, some of the background is I'm pretty sure that everybody in this room, this conference room, or on the phone has some idea that there was a previous initiative. So one of the things we want to stress is from the ground floor and the foundation of this project, we're looking at it from a different perspective of total inclusion. That's why we've invited all of you here today. We want providers to be involved. We want vendors to be involved. We want all types of stakeholders that this project may touch. We want to collaborate with you. We want your communication. We want your ideas. We want your innovation. But most of all, we want your involvement, and we want you to become stakeholders in a project that we feel has a very good chance of success if everybody joins in together to make it an initiative for the entire state of Wyoming. So we're not going to be working in a silo. We're going to be working in an open environment. One of our key goals is transparency and communication. So anytime throughout this meeting, if you have questions, please feel free to voice questions, concerns, ideas as we move through our project and our vision. So the steering committee will have an executive steering committee that will have a diverse group of stakeholders that are involved from different points of view. We'll have formal project governance and transparency overview. Our vision, we will be going through the use cases, our phased approach, our to-be vision, and then our project timeline, which is fluid at this point. We do have some pretty set timelines, but we do have some time built into the project. There are other things we need to consider. So the background is what we're looking for is a successful project implementation. So we're going to really explore all of the options for technology, because one of the keys for this implementation is going to be some of the technological advancements that have happened in the past few years. We have more options than we did previously, so we're going to take full advantage of the CMS direction for interoperability, modularity, interfaces, orchestration. A lot of we can't truly say plug and play, but working from a siloed custom system is a much more flexible platform. We're ready to move ahead. We've got the multi-source CMS and their initiatives, so we're going to model the national standards and the national model moving forward. We are going to engage stakeholders at every step of the way. So that may be a little more time consuming, but I think the value add is going to be far beyond what we could imagine. And we have a holding team, and that includes all of you.
And we do bring, PCG has a national perspective. We've worked with a lot of different states, and we bring lessons learned to the table, mainly my colleagues sitting here and who were not able to make it today. But there's an understanding that we bring lessons learned both from the previous Wyoming initiative and elsewhere across the United States. And we also understand that Wyoming is a unique state in its rural nature, and that it's not a one-size-fits-all when it comes to HIEs and EHRs. And we're all well aware of that, so we're here to bring lessons learned and also make decisions that are best for the state.
So PCG has been with the Wyoming Department of Health since the inception of the planning for this project, starting with the gap analysis, and then some of the most important work they've done is the environmental scan, where they went out to the field last April, and they talked to many stakeholders. They had one-on-one group meetings with the stakeholders. They had a number of surveys that they sent out. They had follow-up surveys that they did. And from that environmental scan, we tried to determine, the state of engagement. And some of the lessons learned that we have from that environmental scan was that many providers are unaware of the HIE. There's misconceptions about how do you connect the HIE, and there's some negativity that we're going to have to overcome from stakeholders feeling like the Wyoming Department of Health is mandating certain technologies or certain procedures. And I just want to make one thing perfectly clear. Business the business is the most important. The way that providers run their practices in their clinics and their business. The business should drive the technology. The technology should not be driving the business. So we're going to be very cognizant of that fact, that the things that providers do are important from a care management perspective, and that their patients and their clients are their number one priority. And the technology has to support whatever their business model is. So we're going to move forward with that vision. So, please feel free to voice any concerns that you have about that. But we are open to your ideas. We want to know what your vision for the future are. Yes, sir. Mr. Carey.
As a part of the gap analysis, I assume there was some root cause analysis done. Are any of the deliverable documents across this work that was done reviewable by the team here?
So the environmental, there will be a website that will be launched for this initiative, and up there right now is the environmental scan. We're just making sure that the website's working properly and going through all the procedures. We'll have to, regarding the other documents, we'll see what we can do. I believe they could probably be made available, but anything that is shareable with the team will be on that the Wi-Fi website.
Right, and we will make that link available to you in your packets after this meeting. Of course, we will have to have our legal counsel review what's on that website, but there will be nothing proprietary out on the website. It will be general information, timelines. We'll give you information on how to register with Public Purchase, who is the software vendor. They're a web-based procurement management system where you can register for updates, alerts, any information on when those RFPs are, when they are actually released, then they'll be available. But then you also have the ability to search for other state of Wyoming procurements that may be out there. So we strongly encourage that if you're interested in, proposing solutions for this RFP, that you register on that website, because that is the most efficient way to know that those RFPs are available.
And Kim, my colleague, and I were intimately involved in the creation of the environmental scan deliverables, so we can share that with the stakeholders here. In the interest of transparency, we did some focus groups around the state, targeted interviews with key stakeholders, some of you are here, and then we did a provider web survey, and the deliverable, the formal environmental scan write-up is a summary of our findings, our observations, and our analyses. So we can make that available to this group, and any questions about anything that's posted on the site can be directed to the PCG and WDH team. And then Tim made a great point earlier that I think is good to emphasize. The WDH team and the PCG team here today, we are not owners of this project, to Joe's point about feeling like things are being mandated. We are key stakeholders along with you, and we're here to be partners with you and work together with you. Very well.
So our mission statement is to promote a healthier Wyoming that work connected and coordinated health IT system that supports effective and efficient health care. So that's our goal. The bottom line is the users of this information, which would be providers, and then ultimately for the benefit of the clients and the patients. So our project goals are to, number one, set the foundational groundwork to develop that partnership and collaboration among all the key stakeholders. And, with a common goal of establishing a sustainable, long-term, pure health information exchange system. Our second goal is to meet regularly to discuss the development. So that goal basically addresses goal 2 is communication, openness, transparency, and collaboration. we identify early in the process any issues, any roadblocks, constraints, anything that we feel or know might impede our progress in making this a success. So I think it's imperative that we discuss any and all concerns right up front so that we are all on the same page and we can address issues and problems quickly and solve them, come up with, you know, how high of a risk are the things that we identify. So I think when you're undertaking something of this scope, it's very important to identify your risks early in the process so that we can come up with either workarounds or different directions or anything that we can identify up front is going to help us, you know, further on down the road. We will have a formal governance structure. PCG will be helping maintain and establish that structure. So we'll have documentation of every meeting that we have. Again, part of the documentation and transparency so that nothing is done behind the scenes or in a vacuum. And we will ultimately, once this project is up and running, we'll work on developing a sustainability plan that works for every stakeholder. So I guess the major thing that I'm trying to communicate is this is not the Wyoming Department of Health and people. It's all of us together as a united team to initiate a successful project that works for everyone. Yes, sir.
So with Joe, obviously the most interested stakeholders are here, either present today or on the phone. Will the stakeholder group be a fluid group though throughout the process?
Absolutely.
And so will that be noted then as documented in the updates?
Absolutely. And so as other people become aware of this project and want to become engaged, that's absolutely something that we want to happen. So it's not, you know, just reserved to these people, to this group of people that came to the kickoff meeting. You know, that will be a fluid group. And we'll have discussions a little later in the meeting about how would you like it. Okay.
So we'll get into the details of the steering committee and the executive committee and the subcommittees a little bit later in terms of logistics and when we'll be meeting and which preferences you might have in terms of your involvement on various subcommittees. But just to give you a brief overview, everyone in this room is part of the executive committee and on the phone as well. And we will meet regularly as a large group. And then we will also break out into subcommittees related to a particular theme that's integral to the overall success of the project. And these will include outreach and provider relations, privacy and security, technical, and legal and policy. So as part of our follow-up to this meeting, we'll be sending out a survey. And if there are areas that you're particularly interested in and wanting to get involved in, please let us know and we'll listen to your preferences and try and figure out what works best in terms of making sure all voices are included and we have enough representation in all areas. And the WDH team and the PCG team will be splitting up as well in representing our voices in the subcommittees. So we'll be working with you as partners there. Any questions on any of the subcommittees here? So this is the general overview. We'll have the larger group meet and then we'll do breakouts. And Andrea later in the meeting will speak to the details of figuring out the logistics.
So now, excuse me, now we get to talk about some of the use cases in technical architecture, which is, I'm sure, the very much fun part for a lot of us. As was mentioned earlier, we've done a variety of surveys and discussions with providers in the state about what use cases were really of interest, what use cases affected care. Also coupled in this is some guidance from the Office of the National Coordinator, excuse me, of Health IT and CMS. Both have a vested interest in what use cases are deployed and how data is exchanged in the state, but they're not the sole stakeholder. Really, the providers are a partner in this as well. So in other states, we talked to providers and worked on HIE and HIT projects. So this is really, when Natalie mentioned the team went out to the field and talked to providers, there was a list of use cases, there was a list of, data sources and other questions that providers could answer and really engage with. Also, as I mentioned, there's some good feedback from the ONC and CMS about, what an HIE should do, meaningful use, how it should support meaningful use, and those sorts of things. So the use cases that are prevalent for the HIE, number one, you see exchange of clinical data summaries. That's the CCDA. That's a clinical document summary that an EHR can output and then bring back in and natively populate. So that showed up as a big use case to share clinical data between disparate EHR systems, right? Someone over here is on Meditech, someone over here is on Cerner, someone over here is on Epic. That data has to flow and not be a PDF that a physician has to print out or mail or fax. Those days are behind us now. The data can free flow and populate those systems. Electronic referrals is very similar to that, but there's a lot of primary care, specialty care referrals going on out there in the marketplace. And this really seemed to hit home with a lot of Wyoming providers, where a lot of primary care rural physicians were referring into larger health systems and providers. And I think there was some feedback saying, we send people off and, sometimes the records don't make it. And then when they come back, the records don't make it back to us. So, how can we kind of fix this loop of data not exchanging between, providers, especially rural going to specialty care? Electronic alerts are, it's a pretty cool use case. In other states, how they've used this is a primary care doc will go in and flag their patients in the HIE. And if that patient goes to an ER, the doc's alerted. Now the doc can be alerted on their phone or their tablet or via email or other mechanisms. There's a variety of systems and services in place to support that, but it's pretty cool, especially for primary care. It's Friday night and you get alerted that a couple of your, very frequent patients have been admitted to the ER. So, you can help coordinate the care. The ONC is really, really interested in these two use cases in the middle, electronic referrals and electronic alerts, because they really see that as coordination of care between providers, and that affects the quality of care and also the cost of care. So they're really, really behind that and supportive of those two use cases. Laboratory results, we know there's a lot of independent labs out there, or smaller providers use hospital-based labs or healthcare system labs. There's also LabCorp, Quest, and regional labs. Getting that data back in, not only to the HIE, but going the last mile and plumbing it back into the provider EHR so the provider doesn't have to leave, eClinicalWorks and go into another portal, get all the information, then type it back into ECW, right? That's really problematic. So trying to get the laboratory results, not just into the HIE where it's aggregated, but also flowing back that last mile into the EHR. That was an important use case. And then talking about the data itself, a record locator service, and I recognize a lot of people may not know what that is. That's a portal where smaller providers, maybe they're a rural provider and they, just have two people in the office and they have two MacBooks, and just basically DSL connectivity or cable modem, whatever. And maybe they're running all scripts in the cloud. They need the ability to interface with the HIE and get the data. So this is a portal, like a web portal, like you go to at Amazon.com or your bank or whatever, that you would sign in and then look up the patient. You'd be able to download the data. If you wanted a PDF, you could do that. If you wanted a CCDA to import into your EHR, you could do that, and really have access and have messaging and communication and have those alerts and be able to do those referrals. So for the smaller provider, the rural provider, The record locator service is kind of a standalone portal that's out there in the wild, right? It's just like you bookmark it in your browser and go there. The larger providers have told us, we don't want another portal. Please, we don't want another portal. So the work we've done in other states has allowed us to see this integration, meaning it's integrated in various ways depending on the EHR. So I know Epic has the ability to take the CCDA clinical summary directly in from HIE right into Epic's tab system, right? And then it just pops, it's sitting there. So when the physician's doing the workflow and they're going down that left-hand column in Epic, right? They go down and down and down. It's right in the workflow that there's outside data that's populated right in Epic. They don't leave Epic. They don't shut down the window, log into a portal, look up a patient, find the patient, download the data, put it on the desktop, and import it back into Epic. Those days are over, right? So we know Epic can do it, Cerner can do it, a couple others can do it. So any ability to integrate the HIE services so the data free flows back into the EHR so the physician in the emergency room, urgent care, pediatrics, wherever they are in this busy area doesn't have to leave their workflow and access another portal. That was abundantly clear from the providers we talked to. You know, at the large systems, they don't want another portal. It's workflow, right? So for the smaller providers, there is the web portal, and we're looking at options to address and integrate that down the road. For the larger providers, we know Cerner, Epic, and some others can support that direct interface type of integration to allow for that data to flow back into the EHR. That was a lot. What questions do you have?
That was a lot, Chris. But actually, it'd be even, I think, helpful to maybe go the next step. And when you talk about different vendors being able to do like what you just mentioned, could you talk about the nature of the data? I mean, is it Epic pulling up a PDF inside the workflow inside their EMR, or is it actually discrete?
When we talk about CCDA integration into EHRs, we're talking about XML. No more PDF, right? PDF is a very challenging document format that we've learned that physicians don't open, don't read, and don't print. If you have to print a document in a care setting, most of the physicians have told us they're not going to print it. They don't want it. So when we talk about EHR integration, we mean the HIE sends the CCDA and XML right into the EHR. And like I said, with Epic, it'll populate, I think it's called Care Everywhere, Care Anywhere, Care Everywhere. That tab isn't lit up, right? If there's outside data, it'll light up. So in Epic, on the left-hand column is this workflow, right? They start at the top and they work their way down. So right in the middle, it's going to pop up and it's going to black and kind of, I don't know if it flashes, but it's going to black bold right there, and they'll see there's external data. They click on it and they can see that there's external data. There's a CCDA right there for it. Right now, I think Epic can import, if they want to import it, it's up to the physician. They can view it, they can throw it away, they can import it, you know, reconcile it, do whatever they want with it. I think right now Epic supports allergies, immunizations, med history, and there's one other. Problems. There you go. There's an Epic guy, right? No. So when we talk about that integration, what we really want is that ability not for the physician to have to open another document or open a reader or scan anything. We want it natively in the EHR with the ability for them to either view it, throw it away, you know, really allow the physician to make the decision of what they want to do with it. So when the patient's sitting there, they can say, I see here from this clinic, you know, you were on this med at this time. And they go, oh yeah, I guess I was, you know, or whatever it is. But really allow the physician the decision-making process within the EHR to decide what they want to do with that external data. So our phased approach to implementation, like we said, we talked to the provider community. We also sent out a vendor questionnaire earlier this year, and we got multiple responses back from vendors talking about workflow, ways to phase the implementation and integration, and how to really get the most bang for the buck, but also get providers using the system and service as quickly as possible. So phase one, we're going to build the core infrastructure and connect the 27 hospitals within the state to feed the data in and also be able to use the data that has been fed into the HIE. So we're going to deploy core components such as the clinical data repository. That's the database where the data, is within the HIE. The MPI, that's the master patient index, that's the identity resolution engine. You are who we think you are, right? So we don't mismatch people together. Rules engines and terminology services. There's a lot of different, forms of the data. There's sensitivity, there's privacy, there's legal and policy. There's different formats of the data. All that has to be managed. So really build out that core infrastructure of the HIE while the 27 hospitals are plumbed into the HIE to feed the data in and pull the data out. So what we're talking about is the ability to integrate all the Wyoming hospitals in phase one as this core infrastructure is built. And at the same time, as much as that EHR integration we just talked about happen in the background. What we don't want to happen is connect the hospitals up and then give them a portal, because we know, the providers just they're not going to use that in the busy hospital setting. So the EHR integration for the usability of the hospital and the feeding of the data will happen at that point. We also talked about the smaller providers, the record locator service, which is RLS there at the bottom. That's the portal for the clinics, the other providers. Maybe there's home care and hospice that needs it. Maybe there's external stakeholders that need it. We don't want to leave anybody behind. So while we're getting, the hospitals connected, there still will be that portal for anyone who's not a hospital. But let's be very clear, the hospitals are going to be the major data contributors to the HIE. So getting them feeding the data in is critical for all these, stakeholders and users to use it. If you're a rural provider, having that hospital data in there and the ability to do those use cases from the get-go is really going to empower you, we feel, to use the system. So that's phase one. Once that's completed, phase two is integration of external trading partners, and this would be LabCorp, Quest, really getting that other rich clinical data into the HIE and flowing back to the providers. We talked about lab results. If we get to a point where maybe lab orders are important, we'll work with the group on that. Medicaid has the total health record, the THR, and there's also public health systems for reporting. And the feedback we got was, less systems are better. So the ability for providers to use the HIE to do their public health reporting without having to go to another portal or that was very important. The THR data, right? There's a lot of data in there. Getting that into the HIE and having that, cross-pollinized here to have the ability to share that data. Really the goal here, phase two, is breaking down any remaining barriers and getting that data into the HIE so that the providers have this one source really to go to for the data. And then phase three, integration of the large partners. There are going to be regional partners, and CMS and ONC are very focused on this. There could be regional pharmacies that are independent. There could be regional additional lab companies, radiology companies, transcription companies, other trading partners. There could be the SSA, right? There could be the VA, could be the DOD. There are other trading partners out here who could be utilizing the data and also contributing data to the HIE. One of those is Medicaid. So Medicaid, can't have HIE data, but they need Medicaid clinical data for improving care, cost, quality, analytics, population health, everything CMS is dictating Medicaid agencies move towards. I'm sure you've all heard all about it and have lots of ideas about that. But these federal agencies, other HIEs, right? Colorado, that's where you'd interface with Colorado and share data. Utah, other partners, to have that ability to share data and exchange that data so that, it's not just locked to the state, because we know a lot of people are going for care across lines. And I think one of the key lessons that we learned overall for some of the other projects we've worked on and with the stakeholders here is you know, the four corners of the state, you know, the state doesn't have an electric fence. People go for care across these borders. So you have to have the ability to get the data to and from those trading partners. And again, that referral use case would be really important. And the alerts use case would be important. Going back to alerts, what if someone in Cheyenne, you know, is down in Denver and then they're admitted to a hospital? Does the primary care doc in Cheyenne want to know they're down there in the ER, right, in Denver? So there's a lot of good use cases for that data, assuming we can get it to flow freely between those organizations.
Chris, because not everyone here has been familiar with the THR and where we are, these aren't entirely sequential because we've already been connecting many of our public health databases into our total health record gateway at this point in time. So immunization is already connected, Eddie's already connected, NEDS is connected. So we've already been in the process for the last several years of connecting our public health and reporting databases into our THR gateway, which is basically it's like a smaller internal HIE, which is coupled with an electronic health record and personal health record system. So that's the structure of the total THR.
And Dr. Bush makes a great point that a lot of time and focus has been put on the THR and those connections. And certainly, you know, CMS and the ONC as partners don't want to see something that's built and working thrown away. So if you go to the next slide, you'll see this is a high-level overview, but you see at the top, that's really what Dr. Bush is talking about, the THR gateway. On the left, you have your public health and reporting systems that are connected. On the right, you have actual users, providers, and others using it. I think it's 31 clinics, 78 EPs, 350 users actually using that EHR component. So we don't want to turn anything off if it works for people, and we don't want to recreate, you know, these public health interfaces. So the HIE is going to have to connect to the THR and send public health reporting back and forth to those public health systems and services. So you see that right in the middle. The statewide HIE, that's that core clinical data infrastructure we talked about in phase one, the CDR, clinical data repository, the RLS, record locator service.
Phase one,
Yep.
phase two, phase three.
And so really deploying that while you see where Natalie was off to the left, getting the 27 Wyoming hospitals interface to the HIE. Some examples of the data are CCDA, HL7, LabRat, PATH, you know, that's your HL7 ORUs. Down at the bottom, as part of phase one, we talked about those smaller providers who aren't hospitals. So there are approximately 2,000 Wyoming providers who would need HIE access via the web portal. So that would be available in phase one as well, right? So you hook up the hospitals to use the data and also contribute the data, and you hook up the smaller providers to actually use the data. And if they can contribute, you know, certainly we're going to connect them up in that manner. If there is some EHR integration for those smaller providers, and we're in the process of looking at some of that now. Let's say that, well, since Allscripts came, we'll give them a shout out. Say there's, you know, 1,000 of the Wyoming providers are using Allscripts of those rural providers, and that's certainly the HIE has to look at that and say, okay, if we integrate with Allscripts directly into the EHR, we get 1,000 to 2,000 providers. And I'm just making those numbers up. I have no idea. But this whole side here is phase one. And then as Natalie said on the bottom there, you start to add those independent labs and other services, LabCorp, Quest, some of those. And then you add your trading partners. Again, there could be a connection to Healthy Way, which is the kind of a federal network of networks. That could be Rio and some of the Colorado. There could be Utah, but certainly Medicaid is a stakeholder. Now, Medicaid can only have Medicaid data, right? So the HIE would filter Medicaid clinical data and send that to the emerging Medicaid data warehouse where Medicaid can use it for cost and quality analysis and control, analytics, population health, care management, care coordination. And there could be models in the future where Medicaid then sends data back to the HIE, and the HIE could run some analytics and population health for Medicaid, I think those models are still being worked out there. But certainly public health up at the top, Medicaid to the right, you got your hospitals and you got your clinics, and then your independent labs, grad, path, pharmacy, other trading partners at the bottom. That's a high level overview. And we certainly don't want to get too much further into this because that will be the scope of the RFP, and we want to keep it very open and, you know, competitive.
So Chris, I appreciate that you pointed out federal agencies would be part of the third phase.
Could be, yes.
But with respect to IHS and direct service tribes, was there discussion had around the value of connecting our PMS?
I mean, if you go back a slide, and I need to be cautious of what I say here. That would be phase 3, and the timing to go from phase 1 to phase 3, I think, you know, once we get past phase 2, phase 2 is a roadmap. Phase 3 is a very strong idea that has been put together by vendor survey, the vendor questionnaire, the stakeholder discussion within the state, ONC and CMS. Due to the timing that it would take to get to phase 3, I don't know that I can answer your question at this time. I think this group would have to look at that type of connectivity in phase 3, right? Do you want SSA? Do you want IHS? Do you want the VA? Do you want Department of Defense? Do you want, you know, maybe DOD's? I just saw their EHRs delayed, right, with CERN, I think it is, and IBM or whoever. But at that point, I know there's some DOD facilities in the state. Where will the HIE get the most bang for the buck, and how will they connect? And certainly, you know, the other states like Colorado and Utah have been doing a good job connecting up to federal partners. So maybe the group here decides, instead of plumbing our own connections after we get our internal providers done, why don't we connect to our sister states, and they've already plumbed it to these, and then we'll just work out a cost model and revenue model so that the data flows. I mean, those are all options that, as a technologist, I mean, I'm happy to list all the options, but really this group has to make those decisions and has to look at an ROI and figure it out.
Well, the reason I bring it up is you could think of it as a federal agency, IHS, of course, but half of what IHS spends on care for natives is spent at these 27 hospitals. And so looking at Riverton and having an appreciation for referral, the focus on referral care across that, flowing that data between the direct service clinics and hospitals and the 27 hospitals that we're focused on in phase 1, there might be a lot of value there. That's why we sort of bring it up.
Yeah, it certainly could be. And there will be an additional, I guess, before the vendor can move into phase 2, I know WDH is talking at this time about an additional evaluation of those trading partners for phase 2 and phase 3. And I think at that time, that would be when it would be evaluated. Again, I don't want to, I don't want to say too much. It's not my job to say who's next beyond that. The scope 1, really, I think Ruth Jo's plan is to go out and talk to the community, you know, once those stakeholders are on board, and really get the buy-in and see who's interested in connecting and what value it provides. But it's a good question. And IHS is Indian Health Services, like I think people didn't. Any other questions on the slide? Just for clarification, you see the black line there is existing today to Dr. Bush's point, and the dotted line, blue line, would be everything that was built, including the blue, infrastructure down here.
Point of clarification, we've got 22 Wyoming hospitals. I thought we were closer to 33.
27 were identified in this initial scope. Certainly, if there are more.
I'd like
there's
34. Okay.
Has there been any talk about when or if you're going to have a outside security review of all
that will be part of the RFP.
And would that be like a different, outside the state contract?
Yeah, probably true. Yeah.
Would that be after phase 3, phase 2, phase 1, or what? That's kind of what I was wondering. When would that take place?
There are.
Or all?
Are you with the state?
Yeah, I'm IT with the state.
Okay, maybe we should talk offline because there's
I didn't know if it needed to be kind of identified and when would that take place?
It's safe to say it's been identified and required on a regular basis, but I certainly don't want to say any more. But happy to get you where we think it is right now.
Okay.
Just to clarify, are we in pre-procurement right now? Are vendors going to participate in this committee?
They are.
Okay. So we are in pre-procurement from a state procurement perspective. This meeting today, we are in pre-procurement.
Correct.
So how are we going to untangle defining deliverables with pre-procurement rules and vendor participation?
That's a good question. We're probably going to have to discuss that, but we do want the vendor participation in like our provider relations and some of the other subcommittees. And we're going to have to be very clear about how that's going to be structured.
Was that an identified issue with the previous HIE efforts? In terms of vendors driving conversations about business requirements or deliverables?
I don't really know. I'm not privy to a whole lot of that background.
But it wasn't part of the scope of your FPC engagement.
At this point, we presented what you'd call an RFI to the community in February, took the responses, took the feedback from the survey writers, and as George said, I don't know if we could go back to the RFP. Oh, there, I gave you a second to do it. This talks about what happened and what's going on right now. The RFP, I guess I would say, is actively being crafted, but
okay,
I kick it back.
Yes, it is. So this is the tentative timeline for 2016 RFP review by the state and CMS. We do want to, completely avoid any type of partiality, conflict of interest, inside knowledge, that type of thing, but we feel like we have to engage the vendor community just in talking to their own providers, showing what kind of technology that they have, because they're going to be instrumental in a lot of those interfaces from the provider, into the HIE. So we do need that communication and interchange from, a wide group of vendors.
I wonder if that should be identified as a project risk, and we'll get to that in a minute, but that might be something to.
It definitely is, could be a project risk.
Define the element.
So, the information and the specific details are going to have to be carefully compartmentalized. So we can talk on a general level. We can't talk specific. So Chris's overview of the technology that we're seeking is as deep as we can go.
And that was what we talked about here today was the scope of the vendor questionnaire, the RFI. So really, in working with CMS, ONC, and the state, providers of those surveys and the vendor questionnaire, this was really defined as the model to go after. And I think the RFP will clarify or ask how the vendors are going to do it, right? The goal is to have clinical data exchange with 27 or however many hospitals there are in a bidirectional manner with EHR integration. So there's a lot of different ways to skin that cat, and the vendors are going to have to come forward with that. But there's nothing been shared today that hasn't been available via the vendor questionnaire RFI or via the stakeholder survey.
So does that answer your question? Okay. And that should be identified as something, we definitely need to identify and look at periodically.
We go back to the phase slide. Because one of the things that I'm identifying is that when we're talking about integration with Medicaid, what about other payers?
Good question. Yes. So again, like the Indian Health Services question, you know, that definitely is something we would like to consider.
Well, it's not like we have a ton of them covering this.
No, we don't have a ton of them, but, you know, it is a consideration.
It might be interesting to see what other states have done with things like mandates for an all-payer claims database that maybe this committee could take, you know, to the governor's office and the legislature and say, okay, you know, we've got this infrastructure, but we don't have all the data. We need help creating requirements for this all-payer claims database, which then would be a connection, or maybe something that the HIE itself would run as part of its sustainability model. Depending, you know, I know there have been legal battles about it. Different states have done different things, but some states, providers and payers actively participate in the HIE, and other states, you know, it's more providers and payers. You know, it's very political. So I think, you know, anything this group figures out, I think certainly having one voice and taking that forward to get whatever support you can, I just think it would be very challenging sometimes to not have a stick and a carrot to get some of those payers, right? So just from what I've seen, I don't know specifically in this state.
I would ask our friend from Correo what their experience was in getting multiple payers to connect to Colorado's HIE.
So connecting is an interesting word. We currently are engaged with 8 payers, and they use the system differently depending on their individual use cases. We strictly follow HIPAA payment treatment and operations guidelines. So that's their limitation, just like it would be a Medicaid participant. They are, you know, the payers, particularly the big private guys, they operate very regionally. So even in Colorado, it's hard to get them to the table because none of them have a primary market share. So they've been slow to come, but because of the work that we've done in areas where, like patient-based routing, alerts, some of the things that you discussed, they've been coming quicker. But it's a slow drudge because it takes a critical mass to get them to the table. They don't have a large share of the market.
Yeah, Morgan, the term critical mass is very critical. In talking to providers, we think that was really one of the large challenges and problems and obstacles to overcome in the second wave, is that there has to be critical mass in this first phase in order for there to be value added and extracted from the HIE. So while, you know, talking about IHS and all of these other large partners can bring a lot of value to the table and are important decisions to make and discuss, not with, you know, WDH or PCG, but the entire steering committee is empowered to be having these conversations and planning for future phases. We need to achieve critical mass first before we jump to the larger 2C vision. Yes.
Ruth, Joe?
Yeah.
This is Dr. Gee. Can you all hear me okay?
Yeah.
Is this a reasonable time to jump in with some comments and observations?
Absolutely.
All right, so a number of things. I heard Chris mention that we were going to build an HIE. I'm concerned about that. Chris, was it you're talking about building or deploying, or what exactly did you mean by build?
The scope of the RFP will empower vendors to bring solutions forward to achieve the goals as listed and outlined herein. So.
Okay, so I think our goals that were outlined so far are much too low but still unattainable. A lot of what I'm hearing is what I've heard 6 years ago when we visited the HIE the first time around. It doesn't look sustainable. Just listening to talk about critical mass, we need a solution that's scalable and sustainable. And I think sustainability has to be top on the list, and not we're going to build it, we're going to roll it out, and then we're going to try to sell it again to the physicians or to those who would get value of it for it in the state, and then try to figure out a sustainability model after the fact. It didn't work last time. It's not going to work this time. I also heard Chris talking about those poor individual practitioners in rural Wyoming that can't afford to have the powerful solutions. I'm an advocate of Friedman's The World is Flat, and with the internet, we certainly have leveled that playing field, and any provider in the state, no matter the size, can have access to an affordable, sustainable health information technology and EHR platform. And, you know, it speaks to the culture of the rural West. I grew up on a farm in Nebraska and was always told that, you know, you can't expect the best because of where you live. That's no longer true, but that's a cultural hurdle we have to get past as a group here to set our expectations high and demand of industry the solutions be delivered to us, and not go out to the vendors and say, well, you know, we're small, we can't connect everybody, and we don't have a lot of patience and money, and what's the best you can do, and then try to buy the best solution and hope it works and hope we can find a value proposition for it. I think the overall scope of what we're doing here, the HIE is not the pinnacle. Creating an HIE is just a small part of what we need to do to reimagine healthcare in the state. And the value proposition does flow downstream to the payers once we start integrating population health analytics into the information that we can acquire and provide to the providers at the point of care taking care of those patients. If we combine an overall vision for the state and not just let's build an HIE, but let's reimagine healthcare, I think we can find the resources, better allocate the resources, deliver the value to those who are willing to pay for it and get the value from it, and create a sustainable new model in Wyoming that can be a beacon for the entire country. But we have to set our standards high. We have to set our goals high. We have to be creative. And so far in the presentations from PHR, a lot of discussion about what's been done in other places. Some of it successful, some of it not successful, but let's not revisit or re-explore what has been done in the past or hasn't been done that hasn't been successful in the past. I challenge this entire group to think creatively, think innovatively. Yes, there's barriers in process and procurement and concerns, but you know, it's time to go big or go home. I think just repeating what we did before isn't going to work.
And that's why you're here.
To instigate and to challenge, I guess.
Well, I totally agree with a lot of what you said. You know, we're going to have to look at this from a new perspective, and that's what we're attempting to do with this group is, you know, to look at those new ways of doing things. So, again, that's why you're here, and any suggestions, you know, in that.
This is Dan Golder. Can you guys hear me? I'd like to piggyback on a little bit of what Alan just spoke about.
Yes, Dan, go ahead.
Sure. I'm hoping folks might be familiar with the Health Affairs Survey that came out on August 10th. And this was an independent survey that looked at HIEs across the country in terms of where are they headed, where are some of the barriers, and where are some of the concerns. And when I read through this, it was concerning to me. We're now down HIEs. We were at 119 the last time they surveyed the country. We're now down to 106. And that's primarily because of cost. What they are concluding is that as high-tech dollars have ceased for HIEs, that the sustainability has become the major barrier to adoption. So they're looking at two main things, sustainability and then higher than anticipated costs, especially vendor fees, being those two big barriers that are hurting HIE implementation. So again, I agree with Alan. I think going down paths that other states have tried and have either failed at or are really struggling to keep their HIEs afloat might not be the way to look at it. Another barrier discussed in that Health Affairs Survey is the competition from vendors for HIE support. And I think we talked a little bit about Epic and Care Everywhere, and Cerner has product. Athena does. And then there are the alliances that are out there. There's Commonwealth Alliance and Care Equality, the two competing alliances. For me, I would like to see us think innovatively and say, if the vendors have good HIE efforts, Commonwealth and Care Equality, can we somehow tap into those, maybe be the bridge between them and serve as a broker to other HIE efforts that are already existing, rather than kind of just going about, as Alan said, the same thing over and over. The final comment I'll make is we discussed some of the things that we want in terms of HIE results, but what we didn't talk about are some of the new initiatives from CMS, primarily ACO support and patient-centered medical homes. Both of those involve data integration along with the transition of meaningful use to MIPS and MACRA. That's where we're headed, and I think whatever solution we develop needs to really address those data integration and aggregation capabilities. So again, I agree with Alan completely. We need to be innovative here. We are in a very rural state, and that's going to pose challenges for us that will make it even more difficult than some of the other states in the country that have HIEs. I fear simply selecting a vendor and quote unquote implementing is putting us down that the path everyone else has tried and been less than successful with.
Dan, this is Dr. Bush, and I just wanted to thank you for introducing one of my favorite topics, which is MACRA and MIPS, because we are trying to transition. We have several of our patient-centered medical homes on this phone call. We are expanding aggressively our patient-centered medical home, and we are trying to, and we have developed a quality reporting system for our ECQMs, electronic clinical quality measures, and the integration of our clinical quality measures with our utilization data and with our cost data is essential as we figure out how are we going to be paying more for quality care and not the volume of care. So this is a big element that was missing the first time around in HIE, and we really want to coordinate quality measures with utilization and with cost. And that is sort of the end game of where we're looking for. It's got to be easy for our practices. It's got to be sort of seamless, which is the goal we've been striving for around this. So that's a very big topic, and I'm really glad that you also recognize this, because that, I think, is very important to the long-term success of this.
So, amen to that.
Yes. So we have considered that, you know, and that's one of the benefits of having providers connected, so that they're able to participate in a lot of these initiatives. And one thing I did want to mention that, you know, we are concerned about. So the funding for this project will be 90% federal funds is our goal, with a 10% state share. So, you know, we have an opportunity here to do some remarkable things if we choose those right things. So I acknowledge both of your concerns, and I think that's why you're an important part of this discussion. I also add the caveat of we have a wonderful opportunity to succeed. We also have a wonderful opportunity to fail if that's what we choose to do. So we have to look at all of these issues, all of these items, all of these concerns, and make the best plans that we possibly can for success. Because I don't know if we'll have another opportunity. So I think we have to go forward with this in agreement, with the collaboration, with the support of the stakeholders, and that means all of the stakeholders to make this a success, because this may be the only opportunity that we have to make this a reality. So I was a little concerned, Dan, about those statistics. That was a bit alarming. So I think an important thing to do from any failed project is to look at the mistakes that they made, to identify those, to analyze those, and to try to avoid those mistakes. I think in some of the big procurements in the last few years, you know, you've seen a number of MMIS replacements, you've seen the HIE attempts and projects, and there have been failures. So I think doing our groundwork and looking at and identifying those constraints, those risks, those things that could definitely cause cause problems. I think we need to identify them up front. So that's another reason, we're having these stakeholder meetings is so all of these, we don't know we don't know what we don't know, and where do we start at the beginning. So I think that's the approach that we have to take. We have to look at all options. We have to look at, again, the vendors that have creative, innovative technology. We present the problem, you tell us how you're going to fix it. So, that's why we're going to have to rely on that expertise, because we don't know how to solve this problem. We're depending on our stakeholders to tell us how we're going to do this. So, any other questions?
This is Chris. I just wanted to add to Ruth Jo's point. This funding is available, has just become available this year under CMS. It's 90% federal if the state comes up with a 10% match. So potentially, a majority of these phases, and I think the funding expires in 2021.
Yeah.
So for the next 4 years, the HIE could be potentially funded between state and federal match and not out of the provider's pocket. So that's one. Having said that, if you take the federal money, CMS will require oversight on the RFP and the procurement, as well as the award and the operation. So this isn't something you could take the money and, say, oh, Linda here runs an HIE company, here's the money. CMS has to approve the entire process along the way. So when we go back to the use cases we talked about, those are use cases CMS wants to see implemented, and the focus of the HIE has to be to support meaningful use. And the programs Dr. Bush, and I'm sorry, I don't know the other Dr. gentleman on the phone mentioned, those have to be priorities. But the ONC and the CMS want to use referrals, alert, and clinical data exchange, and their requirements if you take the money. So there's strict oversight on the funding, but it's a wonderful opportunity to leverage 90-10 funding, 90% federal, 10% state, and really get your HIE kick-started and down the road to sustainability before the funding runs out in 2021.
And to add quickly to Chris's comment, to provide context for all of you, what he's talking about is a letter that, a state Medicaid director letter that came out in late February, early March 2016, which basically provides this new 90-10 high-tech funding as an opportunity for states, and it also expands the types of providers substantially to Medicaid and behavioral health, substance abuse, so picking up people that might have not been involved, and something, again, like Dr. Bush mentioned, that was missing from the first wave, and that speaks to Morgan's point on critical mass as well.
Can I ask you a question really fast? That federal funding, is it set up similarly to the other funding we have experience with, where it's drawdown based on metrics reached? So we had a lot of trouble with that the first time, meeting those requirements in the time that one is met, especially when.
Do you mean the first HIE, or do you mean? Okay, no, the funding for the first HIE came from the ONC, and a lot of that was public-private partnership. This is traditional Medicaid funding, right? So it flows through the Medicaid agency and requires the normal process that Medicaid has been following for, 30 years to procure projects and products like the MMIS, the E&E, all those services.
Requirements as in so many users and the 100 direct to all of those.
It won't have that, but CMS, if you go to CMS, and CMS wants to see everything. They want to see the RFP, they want to see the award, they want to see the contract. If in the contract you say, we're going to pay the vendor when they get the master patient index up, and you pay the vendor and CMS audits you and the master patient index isn't up, you've got a problem, a serious problem. So the payment milestones as identified, it's really incumbent on the state to identify those. And I guess I'd encourage you not to say, we'll pay you when you get 10,000 providers up and running, because that's very hard to do. Maybe a payment milestone will be when you get, you can get 10 hospitals running, you get paid for 10 or whatever. The group has to decide on that and work with Medicaid on payment milestones, but completely different. It's not a grant. It's not the ONC money. It's Medicaid funding under 90-10, and there are very strict guidelines to it. But there's a couple of $1 billion that CMS put out there for states to build this infrastructure. But the primary goal here has to be on clinical data exchange, care coordination, and meaningful use for eligible providers and hospitals.
This sounds like.
Yeah. Can I make a quick comment on that? This is Dan again. This reminds me very much of the Beacon grants that were originally part of ONC, where money was provided. It was also a 90-10 match, but we really didn't worry about sustainability then. And I'm hearing the kind of same concerns here. Hey, we've got money, we've got it for 4 years. Let's get our HIE up and running, and the providers will join. i.e., if you build it, they will come. That's proven to be less than successful. So again, I'm quite concerned about that, as I am on the focus on meaningful use, because remember, with MIPS and MACRA, meaningful use now goes away. MU gets folded into some of the MIPS regulations, so I'm a little concerned that by focusing exclusively on MU, we are missing some other opportunities for integration. So I'm concerned with what I hear here. I think we're focusing on what do we need to do to get the money to build an HIE, rather than what do we need to do for the state of Wyoming that will make us fully functional as an integrated network.
If I may add, the meaningful use, that bar was set so low, and those expectations are so low that it didn't take much to achieve meaningful use and get it reported, but it didn't actually meaningfully impact the healthcare. And so let's not just set our standards as meeting the recommendations and the requirements of Medicare to get that money. Let's think about what we can do for the entire state, set their goals high. Those will be met easily. And when we succeed in the process of exchanging information, studying information, and enhancing the delivery of healthcare in the state.
This is Deb. I just wanted to comment that, working with meaningful use for the past 3 years, I think it's a misnomer to say it goes away. I also think it's a misnomer to say that it's easy to accomplish, especially if you're working with the hospitals who had to come up with lots and lots of money in order to implement the different components for meaningful use. That being said, I agree it should not be the primary focus. However, there are some critical pieces that go into MACRA and MIPS moving forward, which will now be called ACI, Advanced Care Information. And we'll need to make sure that we can, meet the intent. So one of the things that we've always struggled with is the fact that there were rules written, but there was a certain intent with the rules, and a lot of people got tied down in the weeds of, well, it says I can't include this or I can include this. Public health measures are a perfect example of, how difficult it was, and how with modified stage 2, it got changed to actively participating versus saying, yes, we're up and we're running and we're live in production. Again, I don't think we can ignore some of those pieces, but I think there are several use cases. My big question would be, I think it's a great opportunity to utilize some additional funding, but with the thought that whatever we do, we have to focus on sustainability, because anyone who received some of the funding from ONC, including the regional extension centers, had to determine how they would remain sustainable after that money went away. It's challenging. It's a great challenge. It's a fun thing to be a part of. However, you can't wait till the last minute to do it. You have to pre-plan. Again, we have a very interesting scenario here in Wyoming with a lot of people who cross the borders in every different direction. So I think we have to be careful about what our plans are to try to make sure that the information is accessible to the providers providing the care at the point of care, because that could actually still be telemedicine providers as well.
So just again, real quick, we didn't want to get too much into all the weeds and the subshoots at an introductory meeting. For those, we're throwing around all sorts of new acronyms like MACRA and MIPS. And yes, of course, that will also take the RBRBS as well as MU as well as the base modifiers to create QPP. And yes, we as a state are planning on moving forward with turning our current clinical quality reporting system into a QCDR, Qualified Clinical Data Report Registry. And so we've got a lot of moving parts, which is why Medicaid is sort of taking a lot of the lead on this, because there's a lot we have to do with this. And I'm really glad that our clinicians have been paying so much attention and recognize that because we're already, in our patient-centered medical homes, we are collecting all payer quality databases. And so we've been meeting with our patient-centered medical homes, and they're seeing how they're doing with all their patients, not just Medicaid. It's de-identified. We don't have PHI, so. But we're getting what's called QRDA 3 reports that are being manually reported. But we're going to be able to take in QRDA 1, which are individual, and filter out so we don't see non-Medicaid QRDA 1 type data. So we're thinking about all these things. It was just how do you throw all that into a introductory meeting? But I think those are very valid points, and I really appreciate our clinicians bringing them up.
I agree.
So I'm curious, how do we fit this discussion into those work groups? Or is there a work group? Is it across all the work groups? And how do we foster this conversation aggressively in the near future so we can meet some of those timelines?
I think it will have to be work groups. So
It's very odd. Our phone's ringing. My other question, and it's not one that I think anybody can answer today, but if we choose to utilize the funding that comes in, but Medicaid is taking care of 10%, what then are the expectations of Wyoming's Medicaid for moving forward and helping with its sustainability?
So the project right now is located in Healthcare Financing Division in the Department of Health. But I don't think this is envisioned as a Medicaid project. So it's a Medicaid funding source, and it's not a Medicaid project. I think that, we had that slide that had the reuse pieces, that had all, and there's the THR project has built a lot of stuff that I think can be reused, which I do think will help with sustainability, because a lot of stuff wasn't built the first time or wasn't envisioned to be reused. It was all going to be built. In the first model that was separate, they had envisioned building everything themselves, using anything that the state was building for the Medicaid piece. So I think that is,
Can I get rid of everyone?
No, we're not going to do that.
You might have to call it.
I had a question on the 10% funding. So if we move forward and we need the 10%, is that legislatively appropriated? Is that new money that we have to go ask for?
Yeah.
And what session would you anticipate needing to get that on?
Don't we?
Well, we currently have $1 million of state funding that was in the budget appropriated. There is funding currently, which the idea is to leverage that leverages $9 million federal. So that I believe was appropriated already in the previous session, and we're carrying it forward into the 17-18 biennium.
So 1 million general fund, 9 million debt.
Yeah.
And that was in the 16 budget.
That was in the 16 budget and being carried forward in the 17. Yeah. And so that I think is a good starting point for some of this. And there was a lot of onboarding costs in the previous initiative. The first joiners had to pay to join, and there's the chicken and egg problem. There's no value to join because there's nothing there, so you're joining a blank HIE. The first joiners have very little incentive. The last joiners have more incentive because there's actually value there. So if you look at this and you say, okay, I'm joining, and I'm the first hospital, okay, I get the THR stuff, public health stuff, and the other things I've already joined the THR, that's pretty good. I'm the last hospital, or I'm some of these other things, I get a lot more. And so that's the value proposition, but if there's nobody, it's a network effect. If there's nobody on the network, there is no network effect. So the first ones joining have very little value. The last joiners, and I think that's the idea of putting public funds in at the beginning, to get the network effect to be high enough that it is valuable to join, but then you have to think about the long-term operating costs, obviously, because eventually there will be no federal funds, and you have to say, okay, what can we run on in the long, maybe there's no federal funds, I don't want to say that, but maybe there's going to be a less federal funds. The most they ever pay for is 50 or 75% for ongoing operations. In this case, I'm not sure if that's even being offered. So you got to really think about those long-term operating costs in it. But really what we've seen on the THR project is the onboarding, not the ongoing operations, but the onboarding, because you have to design that interface specifically for each EHR. That's really where the huge cost comes in. And then your monthly operating cost is very minimal. So that's, you know, once we get enough of these on, which I believe that a number of them have been onboarded, but in 27 hospitals, that doesn't mean there's 27 EHR systems, right? There could be 4 or 5 primary.
17, maybe 16.
16.
And some of those will be changing.
And you probably don't want to spend the money on the ones that are in the middle of replacing.
Right.
And moving to a more common one.
I know we're over, but just to add on to the funding piece, one of the experiences in the previous efforts was a misalignment with hospital funding cycles and payer funding, or not payer, but provider funding cycles. So the hospitals, and I guess I'm kind of speaking for hospitals here, which I certainly don't proclaim to have expertise with, but to the extent that a county board of hospital commissioners has to approve a budget for a hospital operating in a small community, the lead time to get that funding proposal and the understanding to those decision makers, I think, was vastly underestimated in the previous effort. You know, we say it's a minimal cost, but to some hospitals, $15,000 a year added to their budget is anything but minimal, and it's going to take a lot of educating, a lot of prep time, and a lot of probably demonstration of value that's been received while the infrastructure is subsidized in order to get that commitment from the whole organization. That was one of the lessons we had, is that the CEO can nod his head and the CMO and the CIO, but it's really at the end of the day.
Yeah, I'm just going to comment, that was mentioned in that Health Affairs article as well. The barriers to cost to initial sign-up are significant, and the competition comes from the vendors, right? So Epic and Cerner and Athena have their Commonwealths and their Care Qualities, which are free HIE products included with the vendor software. So that barrier will continue to grow and probably be more profound as we go forward. Again, I would encourage us to look at those two alliances and look at a bridge between them as a potential solution, rather than going out and trying to ask each hospital to incur an interface and integration cost to any HIE we build.
Yeah, this is Chris. I think in the slides, the real focus here was to try and leverage the funding to build as much of the infrastructure as possible, so that the providers, especially the hospitals and the EHR integrations, could be paid for as much as possible. The hospitals and the ambulatory, and maybe, you know, the connection to a couple of lab companies, and the connection to the public health interfaces and the EHR. If you have
Right. The connection is step one too. Remember though that with Epic and Cerner and Commonwealth and Care Quality and Athena, when those HIEs are implemented by hospitals, the workflow is already integrated automatically with the EHR. We still have, even if we make the connectivity, a workflow barrier. So again, this is what the article demonstrated, and I would refer you again to, please everybody read that Health Affairs survey from August 10th. I think it's a very profound article on the challenges faced by HIEs currently in 2016, and we're really at the precipice of planning this effort. I think we really need to focus on what others have done unsuccessfully and find a way around those issues.
I would, so first off, thank you again for having me up here. I get overly excited about these conversations. It just shows you what a nerd I've become in this job. we would love to share our lessons learned. You guys are talking about all of the right topics. The technology is a small component of this process. You have to build something that works for you and for your specific use cases. On your phased approach, I would offer one friendly observation, and that goes back to the fact that people do come and go from our care areas, same in Colorado. I have 6 hospitals currently connected to Correo in Wyoming, and I know that Utah has some connected on the other side too. I believe the QHN is in conversations as well. So in your phased approach, I would actually say that connection to other HIEs would probably end up moving into phase 1. And I don't want to speak for my stakeholders, but I think that they would certainly appreciate the opportunity to leverage any investment that they've already made in trying to further your efforts here.
Thank you.
Very encouraging. Anybody else? And I know that you had your hand up.
It's been asked.
Oh, okay, good. Any other comments?
Andrea, before we close out, would you speak to some next
Yes, yes. So some next steps that we're going to be doing, as Natalie mentioned earlier, I'll be sending out a follow-up email to everybody. There'll be some attachments on it. There will also be a brief survey so we can figure out when I can get everybody back together again. So we know your time is valuable and we want to make sure that we're accommodating to everybody. So look for that early next week. Any additional discussions?
Thank you all for your time today. I think if there are no other comments or questions, we are good to wrap, and we'll be in touch.
Thank you.
Thank you. And thank you for those who joined on the phone.
Yeah, thank you.
Much appreciated.
Thank you.
You bring her back.